Okay, thank you. Let me introduce you. Professor Dr. Daniel Berman is the Director of Cardiac Imaging at Cedars-Sinai Medical Center in Los Angeles, California. He is the most recognized doctor worldwide for his developments and research in cardiac imaging. He is also a pioneer in the concept of multimodality in cardiac imaging and in the development of automatic computer-based method. It's a great honor for me, and on behalf of ICBA, Instituto Cardiovascular, I want to thank you very much for the opportunity of meeting with you as the expert on the subject that concerns us today, which is coronary calcium scoring by CT, a topic of great interest in cardiovascular prevention with many research for the last 2 decades on it. Thank you so much. Can I ask you, how do you perform this scoring, the method?
Well, let me first say thank you very much for that, all the complimentary introduction. I don't deserve all of those accolades.
Sure you do.
But I accept them with honor. So the coronary artery calcium scanning is a very simple test for a CT scanner. The CT scanner has to be fast enough and modern generation in order to get a good stop action scan of the moving coronary arteries. So it's recommended that at least a 16 slice scanner, but preferably a 64 slice scanner be utilized. Yes, I mean, the recommendations are that it be at least a 16 slice scanner with a rotation speed of at least 500 milliseconds. But to do that well, the heart rate really should be quite well controlled. A 64 slice scanner, the more modern scanners, have adequate temporal resolution to be able to do this. So it becomes a study that's not technically challenging. It's very easy to do. So the scanner has to be equipped for cardiac gating, and electrodes are placed on the patient's chest to allow the acquisition during a single phase of the cardiac cycle. The patient gets on the table, has a couple of scout films taken, takes a breath and holds it, and during that single breath, the scan is taken, and then the patient's done. Essentially, it takes more time to get the patient on and off the table than it does to do the scanning. So this scan is a non-contrast scan. There are no injections of anything, no requirements for fasting and that kind of thing. So it becomes a very inexpensive CT scan.
Perfect. Where do you recommend to do it? When? In which scenario? For whom?
Well, I think first we should just talk about what it measures. The calcium scan really reflects the impact of all of the risk factors for coronary heart disease or for atherosclerotic disease that are acting in an individual patient over a lifetime. It's like an integration of all of these factors. And in that, the global burden of the calcium then reflects in the heart this overall lifetime buildup of a specific marker. So calcium in the coronary arteries means coronary atherosclerosis.
Right.
So this allows for a personalized approach to treatment. Risk factors work in populations. So a high cholesterol in 1,000 people means a higher risk of events or hypertension or diabetes. All the risk factors are only factors. They don't represent all of the factors that cause atherosclerosis, and they don't tell us how those factors are acting in an individual patient. And that's what the calcium scoring does. It overcomes all of the limitations of global risk factors when they're applied to an individual patient. Well, the calcium scan ends up being very useful in patients who have an intermediate risk. This could be defined based on the conventional risk scores as a risk between 7.5% and 20% 10-year risk of cardiovascular disease events, or it could be 5% to 20%. In these patients, it's really uncertain many times about how aggressively they need to be treated. It's been shown that a very large number or a large percentage of the patients in the intermediate risk group gets reclassified into higher risk or lower risk on the basis of the calcium scan. The AHA-ACC guidelines have endorsed the use of the calcium scanning as a means of increasing certainty about the need for treatment and its intensity in patients with this intermediate risk. I would just mention that in our country, at least, in our country, pretty much I think throughout the country, the use of calcium scanning has become an integral part of primary care. And I believe that we're seeing that a large proportion of our internists are sending us these patients who fit right in that group. So it's not only something that is used by cardiologists.
Great, so interesting, thank you. How it helps in practice? How do you change your treatment to your patient based on the results?
Well, there's a very strong relationship between the coronary artery calcium score, the standard way we measure calcium, and subsequent outcomes. For every increased grade of calcium, there is an increased risk. It's interesting, even in the lowest score, 1 to 9, that lowest minimal calcium category, the risk is higher, approximately 2 to 1, over the risk of the patients who do not have any calcium. And that's with that minimal score. But so where do we use it? How do we use it? If the patient, the recent data has focused on the power of 0. It's so interesting how patients who have even a higher risk, who normally would be put on medication, end up having a 0 score. And with the 0 score, the 10-year cardiac event rate is extremely low. At 10 years, something like, it's like a few in 1,000 end up with cardiovascular events. So this power of 0 leads to the statement that we do not need to treat with statins and aspirin in individuals. As the score becomes positive, the intensity of treatment recommendations go up. It varies by the different guidelines, whether you only treat after a score of 100 or whether you treat at lower scores. Our Society of Cardiovascular CT has adopted the concept that any atherosclerosis merits treatment. And so we begin treatment even when the calcium score becomes 1. But it's very interesting how high a proportion of the patients in the intermediate risk group end up with a calcium score of 0. Somewhere in the range of 30% of patients who otherwise would have been put on statins end up with a recommendation that no statin is necessary. Now, if the score gets very high, when the score exceeds 100, then we would suggest adding to the standard dose a high intensity statin. For the lower scores, a moderate intensity statin.
Perfect.
Also at a score of 100, we recommend adding aspirin, but do not at the lower scores. And then finally, if the score is very high, then we recommend going ahead and doing additional testing. Somewhere around 20% or so of the patients who have a score over 400, which we call extensive, will have abnormal stress test results. with a score over 1,000, that goes up to be even higher. That we call very extensive calcification.
Right.
In the group then with a score of over 400, there's a consideration of going ahead and doing coronary CT angiography or stress imaging or stress testing. The idea of using coronary CT angiography in the high calcium scores is not universally accepted in the asymptomatic patients, but it is our practice that we do recommend additional testing when the score is over 400.
Great. That was the last question that I wanted to ask you. When do you recommend to continue with further tests? Which would you prefer between them, functional or anatomical or both, or where's the first one and how do you continue? We like to think of both. No, I know.
Okay, so here, I guess there's a couple issues we should talk about more, and that would be what do people do differently? How does it really affect practice and the patient? And then the other one I'd like to address is a cost effectiveness. But let's talk about the coronary CT angiogram.
Yes, please.
I believe that if the score is less than 1,000, or then in the range of 400 to 1,000, that coronary CT angiography may be the best additional test to see if there is functionally significant disease. Now, importantly, things like the ischemia trial have taught us that it's not just all coronary artery disease that is associated with ischemia would result in a change in management. But what we're looking for is the high-risk coronary disease, stenosis in the, let's say, the proximal vessels or the left main, where we would consider much more aggressive treatment. Yes. We do, though, consider ischemia testing, particularly in sites where we don't have coronary CT angiography that is of such high technical quality and where the expertise might not be present, in which case we believe that stress imaging is better. And then finally, you know, nobody's tested whether the calcium treadmill is how that fares compared to the other studies. So it's conceivable that even a treadmill test could be used in the patients with the higher calcium scores.
Right.
In terms of how it affects practice, I mentioned the statins and the aspirin, but what I didn't mention was how it really affects the patient, and that's very important. Many patients are reluctant to take medication, but when you can show them that they've got disease in their artery, and then you tell them about the consequences of that, the likelihood that they'll take medications goes way up. And we've tested to see, well, how often are patients on their statins after they've had a calcium scan? It's commonly known that patients often will get a prescription for statins and then just don't take them. But the frequency of adhering to treatment recommendations when the calcium score is high has been demonstrated to be increased. Years ago, we did a trial called the Eisner trial of 2,000 patients who 2/3 of them had scanning, 1/3 just had risk factor assessment and recommendations to the patients. And what we found is that the patients who were in the scan group they had actually over a 4-year period of time, their at that time it was the Framingham risk score stayed the same, whereas all the other patients had the expected increase in their Framingham risk score. And it was related to an improvement in diet, an improvement in exercise, and an improvement in their cholesterol and blood pressure levels. So it has a dramatic impact. patient care in a large proportion of individuals. It also allows us to give these recommendations, as I alluded to, about diet and exercise. Then what about costs? We found out in the Eisner trial that overall costs were not different if we used scanning versus no scanning. In patients who had a 0 score, the cost of downstream testing and the overall cost of care of the patient actually went down because there was much less diagnostic testing performed in the patient. And when the score was positive, then depending on how positive it was, the cost might go up, particularly when it's a higher score, like over 400, where, as I mentioned, we would often be suggesting that further testing might be indicated.
Great. So great about all the information you gave us, so clear, so wonderful. We are very, very, very thank you. It's invaluable, the collaboration that you gave it to us. It's going to be a pleasure to have you at the pre-congress of ICBA. Thank you so much.
Oh, thank you for the invitation, Paola.
Thank you.
Very
Thank you
much
so
appreciated.
much.